to Sir Robert Francis, who is the chair of Healthwatch England, who's going to open the event for us today.
Well, thank you, Jenny, and thank you to everyone for joining us for what I am absolutely confident will be a tremendous curative to the events of last night. And thank you very much for joining us despite that, even if you've had to put your certain shirts away in the cupboard again. This is a very important event for us because you, the commissioners, are literally our lifeblood. And I'm absolutely certain that we have a lot to learn from each other. And we at Healthwatch England are very keen to learn from you. So that's why we're very happy to see you all here today. Now, before I say a few more words about Healthwatch and our aspirations and our plans for the future, we do like to listen to you. And throughout this conference, every now and then, we're going to ask you a question. So I'm going to hand you over to Jenny, who's going to ask you a question and let you vote on it. Jenny.
Okay, so I'm going to ask Judge to make the poll live, please. We are aware that it's a number of, well, it's over a year, I think, since we last had an event for commissioners, and we're interested in understanding who we have in the room. So in the chat or popping up on your screen, we'd like to share with us, please, how long you've been responsible for commissioning a local health watch. So for some of you, perhaps you're new into post and this is the first time we've seen you. Perhaps for others, you've been around for longer, perhaps even as long as back in sort of 2013, 2014. So if you could just use your poll now, that'd be great. You can see the responses coming in. So it's a pretty even split so far between new people and people who've been here more than 3 years, with perhaps slightly more people who've been here less than a year. So interesting and welcome. It's great to see you all here. So Sir Robert, you're speaking to a room with an even split, I think, almost perhaps with a slight percentage above on less than a year.
Right. Well, that's really interesting. I think what I'd like to do, and I apologise to the old hands to whom some of this will be quite familiar, just to explain a little bit about the background to Healthwatch, at least from my perspective. And the first question really one might ask is, why does Healthwatch exist? And I think it's an important question because certainly when I took over as chair, and I proudly told people I was chairing Healthwatch, quite often there was a bit of a blank. I think there's less of a blank these days. But what is Healthwatch? Well, it's one of the few parts of the Lansley reforms of 2013 which no one has really quarrelled with since then, and which will continue under the new reforms which are now being proposed. And I think it's fair to say that we are, as a concept, unique in being the only entity which has a presence in every area, local authority area in England. We are a statutory part of the system funded by the taxpayer, yet we are independent in the judgment and views we form, based, of course, on the voice of the people we talk to who use services. And we are expected to and are given freedom to give voice to those judgments and views. Our scope of interest covers the whole of health and adult social care and doesn't focus on any one condition or part of the system. And importantly, we form partnerships with others who know more than we can know to strengthen both their voice and our voice. The job given to us by Parliament is to listen to the experiences and views of local communities and people who use services, to report on that to relevant decision makers, and to ensure that those views are fully taken into account when and where decisions are being made. Importantly, we believe that we're there to ensure that those who suffer most from the inequalities in health and are not listened to are identified and are heard. And we relay health service. So that's all about what we receive and what we hand out to decision makers. But a very important part of our role is information giving to local communities. In other words, We are there to help people find the services they need and to explain the services to them. So how do we do that? Well, as you probably all know, we have two distinct entities. One is Local Healthwatch, there being one in every primary local area in the authority area in the country. These provide an invaluable listening post. That they're more than being a passive listening post. They are an active means of local involvement in decision making, scrutiny and accountability. We at Healthwatch England provide national level support for the Local Healthwatch and a channel through which national decision makers hear local voices. And our current revised strategy has an emphasis on seeking out the voice of the most vulnerable and seldom heard groups and identifying health inequalities often experienced in those groups. That's just one, but perhaps at the moment, the most important priority that we have. What is our governance? Well, if there's one comment one would make about the way Mr. Lansley set us up, it is that we have an odd and asymmetrical structure. The part that you're most concerned with, the Local Healthwatch, is commissioned by local authorities with funds provided by the Department of Health and Social Security, but not directly. It goes into the funds that the DCLG provides to local authorities and is not ring-fenced. As we all know, local authority funding generally, but Local Healthwatch funding in particular, is a Byzantine business, and it's one area where many think there could be improvement. We, of course, recognise how challenging resources are for local authorities and that this pressure is not going to go away anytime soon. Our state of support reports, which we provide to the Secretary of State every year, show declining resources and increasing challenges for Local Healthwatch in providing an effective service. However, we do draw some mild encouragement from the fact that the rate of decline in funding seems to have reduced in this last year. The Healthwatch England Committee, which I chair, is a statutory subcommittee, oddly, one might think, of the Care Quality Commission, and we're funded by a grant from the Department of Health and Social Care to the CQC. I'm appointed by the Secretary of State directly. We don't tell Local Healthwatch what to do. We have no power to do that. However, we do control the brand in the sense that it is up to us to provide the license by which Local Healthwatch is entitled to use the Healthwatch name. While we have no directive powers in the sense that the Secretary of State is apparently now seeking over the entire health service, wouldn't we like to have that? Probably not. We do encourage and support Local Healthwatch to share good practice. We propose projects, we propose priorities, and increasingly we seek to see the Healthwatch network as a family, all of which is allied towards shared strategic aims. We offer a quality framework. We provide support for internet interaction with the public, and we support common work. A big example of that recently being the work that was done on the NHS long-term plan. Our strategic goals at Healthwatch England, which we recently reviewed, are firstly, not surprisingly, that we have a high-performing Local Healthwatch network. We aim to find out people's experiences on health, public health and social care services. We seek the views of seldom heard people about the barriers they face and apply a focus, and we hope a relentless focus, to health inequalities. It's no use just listening unless you do something about what you hear. So we are determined to act on what we hear to ensure that the information people provide to us helps improve policy and practice. And we all know that engaging with people to find out what they think, what they would like to see happen is not easy, particularly in seeking to find those who are not heard very often. But we do believe that at Healthwatch, we have developed considerable expertise in what works. And we are determined to collect together and to share our expertise in engagement. We believe our network is an amazing resource of good ways of encouraging communities of all types to share their views on a whole range of issues and concerns that can arise. And certainly this is not a field of practice talking to people where one size fits all. And in particular is one where a formalistic and tick box exercise type of consultation really has no place anyway. And finally, of course, we're determined that the voice of people has an increasing impact. We like to believe that local authorities really value their local health watch and that do so, of course, when they're working well. We are an invaluable source of intelligence for them as for the rest of the health and social care system. So this is, of course, a time of considerable change, and I'll come back to that in a second. And but on the whole, we would say that local health watch has never been more needed. I think the pandemic has shown that. Just a word or two about our recent achievements, and these are in no particular order, just to put some flesh on what work we have been doing. And this is nationally, but everything we do nationally is built on on the efforts of local health watch. I would commend to you, if you've not seen it, our recent work on vaccine hesitancy, which was an in-depth piece of work to find out from people who were reluctant to have a vaccination for COVID, why they were hesitant. And I think there are many lessons to be drawn from it as to public health lessons about how to persuade people. What are the means of persuading people to do the right thing, if that's what you believe is the right thing? We've recently reported yet again on dentistry and the difficulties people have in accessing NHS dental service provision. I'd personally like to highlight our report a year ago now, time flies, on patient transport and about the particular challenges that users in rural areas have in getting access to services. And it's a classic example of the services not always thinking about how to get services to people rather than expecting people to come to where it's convenient for the service to be. GP access has been a particular challenge, as we all know, during the pandemic, and we've done our best to highlight that, as we have concerns that people have raised with us about blanket policies for DNA, hospital discharge during COVID, and care home visiting guidance, which I think gives you some sort of idea of the range of issues the Healthwatch nationally and, of course, locally covers, and not surprisingly so, given the complexities that face our system every day of the week. So then a brief word about the new world that the Secretary of State, now new Secretary of State, promises us in the bill that was published in Parliament last week, which is all about legitimising what has been happening for some time, namely the move towards integrated care systems and the emphasis on providing a seamless service rather than individual providers doing everything with different strategies and so on. I'm not going to talk at length about this, but with this planned reform, we see that we at Healthwatch have a real chance to strengthen the patient voice and its effect on the strategic direction of the health service in particular, but also social care, both nationally and locally. But it does mean that we need to be represented at this new level, namely the ICS, in a way which, of course, the current legislation didn't envisage that we needed to be. But we believe that we are uniquely placed to give people, local people, a voice at systems level as those systems plan and deliver their services. We can support the public voice within and across the areas covered by ICSs, which of course are different from those covered by local Healthwatch. And we would of course have to do that by ensuring that local Healthwatch can collaborate with each other to produce a more unified voice within those ICS footprints. We believe that local Healthwatch, by knowing its place, knowing what's going on in its place, can support systems to know and understand communities and their need and provide that vital link without which perhaps strategy is unlikely to work. And finally, with our contact with the wider voluntary care and voluntary service sectors, we can facilitate engagement with them as well. So we propose and have proposed that Healthwatch should have that function as well. And I'm glad to say that that is recognised in the bill currently before Parliament. And being a lawyer, let me just quote what it says. In preparing a strategy, an integrated care partnership must involve the local Healthwatch organisations whose areas coincide with or fall wholly or partly within the area, and involve the people who live and work in that area. It's a simple word, but we believe it's the first time that a bill or legislation recognises not just there's a need to have regard to what local people say, they must actually be involved in that. How this is to be worked out in practice, of course, needs to be seen, and there may well be differing solutions in different parts of the country. But we've already been hearing in our interactions with the leaders of ICSs a considerable degree of enthusiasm for encouraging Healthwatch to be involved, which can often mean being actually on the board rather than just a visitor to it. So we suggest to you, albeit tentatively, that local authority commissioners will need to accommodate in their commissioning of Healthwatch the existence of this new function. But as I say, how that is to be worked out perhaps still remains to be seen, and it's a matter for discussion. Anyway, I think that's enough from me. Once again, thank you very much for joining us. As I've said, I don't think there can ever have been such a vital time as this for us to ensure the public have the benefit of a vibrant and effective Healthwatch network. And I hope you enjoy the rest of today's meeting. And with pleasure, I hand you back to Jenny.
Thank you so much, Sir Robert. So Sir Robert's given us a really good kind of context to the rest of the session. Today we are going to hear from Jacob Lant, who is our Head of Policy and Public Affairs at Healthwatch England. We're also going to hear from some local commissioners, because I think nobody tells the story of commissioning an effective local Healthwatch better than the people here in the room. There'll be an opportunity also for questions, and then we're going to move to some breakout rooms so that you have an opportunity to network and learn from each other, which we know from previous events is some of the things that that we value most. So I'm going to hand over to Jacob, who is going to talk to you a little bit more in depth about the sort of context for commissioning a local Healthwatch.
Thank you, Jenny, and thank you, Robert, for your opening words. So I won't go over all the territory that Robert already covered, but I will pick up on a few more detailed points that might be helpful, particularly given that we've got so many people who've only been responsible for commissioning Healthwatch in the last year. So you might be quite new to this, so some of these more detailed points might not have come across your desk yet. So the first thing I'd probably say is, as Robert mentioned, we're a creature of the 2012 Health and Social Care Act. But it's very clear that although the new bill is replacing some of the elements of that act, that actually Healthwatch is one of the elements the government's really keen to keep and to build on. And in fact, when asked in February earlier this year, to name some of the achievements of the Lansley reforms, Lord Bethell said in the House of Parliament that he gave three key achievements, and the first one was Healthwatch, really sort of highlighting there that the government sees this as a very positive thing. And we've also seen government praise the role of Healthwatch and giving people a voice and a say in how health and social care services are run, both pre the pandemic, but also really crucially over the last year, how we've responded to the pandemic. So what does the legislation say you should do? Robert touched on this a bit, but we also have a handy guide that pulls together the legislation and the guidance for you, which we can circulate again to any new commissioners who may not have seen that. And it pulls together the main statutory roles, which are around, as Robert touched on, promoting involvement, carry out research and engagement, obtaining the views of local people, reporting and making recommendations to local providers and commissioners of services, providing advice and information to local people, and then collectively using that insight across the whole country to inform our national work at Healthwatch England. As well as the statutory function that we have some statutory powers in Local Healthwatch. So things that we can do, for example, something called Enter and View, which you may well be familiar with, which is effectively Local Healthwatch have the power to visit publicly funded health and social care services and see how the care is being experienced by people and use that to make recommendations. Local Healthwatch also have the power to collect information from commissioners and providers, similar to the Freedom of Information Act, but very specific to Local Healthwatch. As well as the powers, we have some statutory roles, which, for example, things like a seat on the Health and Wellbeing Board. So every Health and Wellbeing Board around the country has to have a seat for their Local Healthwatch. We also have a statutory role in the creation and informing of JSNAs. And in the vast majority of councils, also Local Healthwatch play a significant role in scrutiny. Our remit covers children and adults. So we also cover health, social care and public health. So we cover a huge array of services which you can call on your Healthwatch to help you with. But just because we have such a broad remit and we have, as Robert was saying, limited resources, doesn't mean we cover all of that in detail and certainly specifically in 1 year. So Local Healthwatch have to prioritise where they're going to focus their efforts, and they often do that in partnership with their commissioners to work out where they can make the best contribution. Couple of things just to say about the money that you get for Local Healthwatch. So this is, again, as Robert was saying, it can be a bit confusing, but essentially there are two pots of money. There's the Local Reform Community Voices grant, and there's the public, the general grant for local government that comes through CLG. Now, it's important to the really key thing there is that the LRCV money, so the grant money for the Department of Health, is the smaller part of the funding. It accounts for about a third of the overall total that the government makes available for Local Healthwatch, and it makes clear in the letter that that is the smaller part. So just because that's the bit that you see as a line for funding, it's not the only money you should be receiving for Local Healthwatch from central government. And if the department were here today, that's a point they'd probably want to make to you. So that's on the money. And finally, on the ICS point and the kind of the new bill, Robert touched on why it's important that Healthwatch are involved in this and why we, Local Healthwatch and commissioners, work together to work out how we operate at an ICS level. We are working very closely with NHS England and the Department of Health on the development of the guidance that will come alongside the bill. That will flesh out in more detail how a Local Healthwatch can collaborate with each other and work with representation at the ICS level to ensure that communities have a strong voice and say in the decisions being made at that level. It's very clear from the bill that the government's keen to keep a strong Local Healthwatch in place to support place level decision making. That's really crucial. And that's a real positive to come out of it. And I think the main thing I would say about our next steps on the bill is that we're pursuing the resourcing to support this. So obviously, as commissioners, you've got your pot of money to support local Healthwatch, to fund local activities. And the biggest area where you can help us is say, we want local Healthwatch to be involved in ICS decision making, but doing it on the existing resources that we have available is going to be really, really challenging. And we need all the support we can get to make a case for more investment in the Healthwatch network, so that your communities can continue to have a say in the decisions, not just in your local authority area, but in the ICS systems where the decisions will be affecting your local residents. We have, as I was saying, Robert also touched on the finance stuff earlier. We've had a detailed briefing that we do on the finances every year of Local Healthwatch. We've got the legislation briefing, which tells you all the legal rules for commissioning a Local Healthwatch. And we'll also be doing briefings on what the new legislation means for Healthwatch as the bill makes its way through the House. So watch this space and we'll keep you informed with all of that as we go. I'll now hand back to Jenny with so Jenny, over to you.
Great, thank you so much, Jacob. Like I said, you will have the opportunity to ask questions. So we are just going to recap, and apologies for those third of you who have been here for quite some time, that this will be going over some old ground, but for the newer people who are responsible for commissioning Local Healthwatch, we thought it would be useful to talk through some of the elements of good commissioning, and then we're going to move on to talking to some commissioners, and they're going to talk about their experience. I guess the first thing to say is that these elements of good commissioning of Local Healthwatch are included in the toolkit that Healthwatch England has produced for commissioners, which I have posted in the pack. But we're just going to go through some of the key elements for you. So this is our little checklist for good commissioning. We're going to run another poll while I'm doing this, which will help us to consider what does it really mean to be effective. So how do you, in your commissioning role, consider how to measure the effectiveness of your Local Healthwatch? So we're going to run that poll while I take you through this checklist. Okay, so within your specification for and your tender process for Local Healthwatch, here are some of the things that you should be considering. So the model for a Local Healthwatch is prescribed that it should be a social enterprise. Now, what that means in terms of how the organisation is constituted might be variable. So it might be a KIC, it might be a CIO, it might be a charity, but that's also incorporated as a company limited by guarantee. And we see across the network that there are lots of different models for how Local Healthwatch have been commissioned as a social enterprise. So some Local Healthwatch are standalone Healthwatches that just exist to deliver the Healthwatch contract in their local authority area. And some of those were set up specifically to do that. So they're registered in the name of Healthwatch North Tyneside, for example, where I used to work. Other Healthwatches that have been commissioned are hosted within larger organisations that might also deliver other contracts, some of which might actually be the delivery of health and social care services. So what they deliver as Healthwatch is part of a bigger organisational structure. And we also see a model where there are multiple providers of Healthwatch. So they deliver contracts for Healthwatch across multiple different local authority footprints. And that might also mean that they're hosted. So they might be multiple providers, but they also deliver other services, for example, health and social care services on contract. So there are lots of different models of how Local Healthwatch are commissioned, and in your consideration for your procurement, you might want to consider what that looks like in an ideal scenario in your local area, and thinking about local connection as one of the things that you might want to consider. So the guidance, the sort of statute sets out that you should be contracting one organisation to deliver Local Healthwatch activity. We do see some consortiums coming together, but the contract should be with one lead provider. And that lead provider should correctly call their Healthwatch the Healthwatch and the name of the local authority. So I'm going to keep using my own example where I was a director, Healthwatch North Tyneside. Even where you have multiple providers, providers, there still needs to be a branded, recognisable brand at a local authority level area using Healthwatch's branding. And that kind of brings me to the trademark. So your specifications should make reference to the requirement for the provider to apply to Healthwatch England to have the trademark to use the brand of Healthwatch with their local authority area. And to support this, we ask that local authorities share their specifications with us before they go out to tender, so that we can just check that that it's compliant. Because what might happen is that if they don't apply to us to use the trademark, or for example, if there's something in the specification that would compromise the use of the trademark, Healthwatch England in theory could say no. So an example of that would be something in a specification that would compromise the independence of the local Healthwatch, and therefore they wouldn't be able to fulfil their statutory duties. As local Healthwatch, they are required to comply with the public sector equality duty, and that should be something that's reflected in the specification. But also Healthwatch England are very keen to ensure that we are beyond reproach in how we are ensuring equality, diversity and inclusion in our work, and we would hope that local commissioners would include equality, diversity and inclusion clearly as an indicator within the specification. Obviously, we're about reaching people whose voices are seldom heard. We're about making sure that inequalities are tackled, and so that should be reflected in the specification. There's also a requirement that local Healthwatch share their information with Healthwatch England, and that's to enable us to be able to challenge areas at a national level where we think action is required by NHS England or the Department of Health and Social Care or other government departments to ensure that people have access to the healthcare that they need. And so in the specification, sharing with Healthwatch England should be reflected, but also using taxonomy and demographics that enable us to use that information at a national level and have it much more sort of powerful. And so therefore there should be data sharing agreements in place. This one, I think, is one of the core pieces of sort of good practice commissioning. Every local Healthwatch has a requirement to have a published decision-making procedure, and that should be reflected in the specification, and that process should involve volunteers and the public. And I think that this is something where local commissioners have a core role to ensure that local Healthwatch doesn't have any conflict of interest, and that local people are involved in setting the priorities of what issues or themes the local Healthwatch is going to carry out within that year. And the kinds of decisions that should be covered by a good decision-making policy are what priorities they're going to use their finite resources for in this vast health and social care sphere, how they're going to spend those resources, what methods they're going to apply to engage people. And that's never more relevant now than during the pandemic, where the decision to make face-to-face engagement versus online engagement is needed. When to refer things to overview and scrutiny committee, even the writing of letters to request for information, or the making of recommendations based on findings, or the decision to use the powers to enter and view services should all be covered by a good decision-making policy. And that's very important for the purposes of being transparent, and that policy should be published, but also the decisions taken should be published, which brings me to the next point, that the meetings that are held by the governing bodies of the Healthwatch, be that a board, because they're a standalone organisation, or an advisory board that sits within a hosted organisation, those meetings should be held in a way that's accessible to the public, and they should publish the minutes, which should set out any decisions that are being taken. And it's useful to consider that in your commissioning guide, particularly where you have a hosted organisation, that the board, who may be delivering services on the one hand, as well as hosting the local Healthwatch, shouldn't be compromised by any conflict of interest that they have in health and social care delivery. So an advisory board has an interaction with them to make the priority decisions of the local Healthwatch. Every local health watch is required to publish an annual report, and that should be in your specification, and they're required to publish an annual report by the 30th of June, which gets sent to Healthwatch England so that we can report back to the Secretary of State. The specification, I mean, this goes without saying, and I'm sure most specs would include the need to comply with GDPR, but it's also worth pointing out that that local health watch in this context are seen as a public authority, and therefore the freedom of information legislation would apply to them. And many times where contracts have transferred, there's a need to transfer the data between an existing and a new provider, and that should be covered in the specification. And finally, from me, safeguarding duties, which I know would be a standard. With Local Health Watch, obviously they have a role to not just ensure safeguarding through their own activities, but also in some of the acting as a critical friend to the system in discharging their safeguarding duties, and you may wish to consider that as well. So I'm going to hand over to Gavin, who is going to talk you through a little bit about some of the ways that we can help you with effective Local Health Watch.
That's great. Thanks, Jenny. Yeah, so one of the things that Robert talked about was our role in helping local authorities when they're drawing up their contract specifications. And one of the things that we wanted to set out really was the key ingredients around delivering an effective health watch. That's one of the things that you're required to do. So we wanted to get the three different elements of running a health watch. Healthwatch England, local authorities and the provider themselves, and get that sort of common understanding. So to do that, we've set out those key ingredients in the quality framework that's up on the slide. And we spent quite considerable time developing that with Healthwatch themselves, but we also worked with local authorities too, because you were telling us about the various elements that you wanted to see reflected in that. So we had a series of events back in September in 2019, which I can see some of you were at and contributed to. And we took all that learning and all the other learning that we've had through the 6 or 7 years that we've been supporting local authorities, and reflected that in the quality framework. So it has 6 key areas. So familiar ones would be the engagement activities, the statutory activities that Jacob talked about, but it also covers the decision making, which is a key element of running a health watch, deciding on their priorities and how that's done, including the involvement of volunteers and local people generally. But it also covers the important element about the difference that Healthwatch actually make through influencing and having impact. So we went deliberately for a self-assessment route, and that's because the wide remit of Healthwatch, the variation and the requirement to respond to local circumstances and the context that they operate in. And the various levels of funding that Healthwatch operate to. Jenny, could you just jump back on the slides, please? Thanks. Let's quickly get my slides up. So that's it's a self-assessment process, and then as a result of that, Healthwatch do the self-assessment, then produce an action plan on the areas of improvement. So we've now had about the first tranche of Healthwatch have actually completed that, and we are really seeing some really good results as a result of introducing the quality framework. So far 57 have either completed or in the process of completing it, and we have set ourselves a target that all will undertake it by March 22. And we're seeing some sort of tangible outcomes as a result of that, including actually, a much greater focus. I think this is something that commissioners often say, they pose the so what question. What difference does the Healthwatch actually make? So we're really supporting Healthwatch to be able to answer that question around how they contribute to improving outcomes and the reporting requirements around that. But there are other areas, you know, the importance of their boards, whether that's an advisory board or whether that's a board of trustees. So whatever their governance and decision-making model, they've really focused on trying to strengthen that. And then other ones have really taken a real opportunity to reflect on the approach that they've got around equality, diversity and inclusion, and really focus on that. And then with local authorities themselves, how are they using the quality framework? The commissioning guide has examples within it of how the quality framework can be used throughout the commissioning process. But we're seeing it increasingly in tender specifications, and some are using it as the basis for monitoring. So they're adapting the kind of outcomes that are implied within the quality framework to be used for their own monitoring arrangements. So that's a whistle-stop tour of the quality framework. But one of the areas was sort of around outcomes. So I'm going to pass back to Jenny, who's going to give a bit of reflection on the difference between outputs and outcomes side of things. Jenny.
Thank you. So just to go back to the poll, so there are 43% of local authority commissioners who are already using the quality framework as the route to monitoring. And there are about 37% of them that said that they carry out regular monitoring visits. And one of the things that I think is quite difficult for local authority commissioners in ensuring an effective local health watch is, what does it really mean to have impact as a health watch, and how can you disaggregate the impact that a health watch has from the impact that a system has overall in the way that it's operating and listening and making changes based on their sort of qualitative understanding of what's working, based on their data of how services are being used, but also a qualitative understanding of why that patients are facing kind of delays in care, or what does it really feel like to use a service. So we thought we would just touch a little bit on the work that we've been doing to support impact to be better measured across the Healthwatch network, but also to help you to reflect on how you can commission for impact or outcomes versus outputs. So John Turner, who is one of our regional managers, leads on our impact programme, and he's been helping Local Healthwatch to work on theories of change for some of their specific projects. And so we hope that you will see through the annual reports, but also through your interactions with your Local Healthwatch, some of these messages coming through, but you can help in the way that you develop your spec. So I'm going to give you an example of output-based commissioning, which is something that we sometimes see, which is sometimes problematic. So you can see on the left-hand side there in the red box, the output might be often that we see in specifications things like the local health watch should recruit and support at least 20 volunteers per year, or speak to at least 500 people per year, or sometimes those numbers are higher. So where it's really like quantifiable, and I can see why that would be attractive to a commissioner because it's very measurable. However, that doesn't necessarily guarantee that you'll have an effective local health watch that are having an impact that you want them to have on improving health and social care services by amplifying people's experiences. Yes, you'll have volunteers who are supported, and yes, you'll be gathering people's views, but so what? So what does that change? What happens with that? I'm sure output-based commissioning leads to impact for some local health watch who are really good and really effective and will be using the opportunity to create impact. But if you truly want to commission for impact, you need to be aware of the unintended impact of commissioning output-based models on the independence. For example, we see sometimes specifications that set out how many enter and views should happen and which services should be enter and viewed. And obviously that means that the decision making is by the local authority rather than by the board of the local health watch, which is not what we want to see. So the next row down with the green box is an example of how to commission on an impact basis. So it means that you will need to work with your local Healthwatch to gather impact in a different way. It means that you will need to look at the quality framework, but also looking at things like theory of change to put in place so that you can measure that through your monitoring visits. But here's an example of there is evidence that commissioning or services has changed in response to the insight shared by local Healthwatch. So this sort of evidence-based model of impact could be integrated into your specifications. Or you could look at it from an outcomes-based level. So Healthwatch produced a report setting out trends in patient experience relating to an area of a priority identified by local people. Or an outcome could be that all decisions taken by local Healthwatch are published and have been informed by local people. And the output of that might be that 40 people shared their views. And those 40 people's views may have been so influential in the way that that story was told about dentistry that it changed the way that dentists in the local area operate. And that's a really good outcome. And that local people might have co-produced the recommendations. So it's very difficult to pick out in that situation. So I can think of an example myself was where I was a local Healthwatch director, and we worked really closely with system actors to talk about changes to the crisis mental health services, because they knew it was an issue from their quantifiable data. We knew it was an issue from the stories that were coming through to us. And eventually that led to a new commissioned service. And we worked really closely with people who had mental health needs in that area, who needed the crisis services to make those changes. And it was a really good impact. But we couldn't say it was just ours because we were working collaboratively with the system. So how can you measure the impact and outcomes of a local Healthwatch? Well, within your specification, you could ask that theories of change for particular projects are put in place. And you could look at those theories of change together with them when you're doing your monitoring visits. Integrating the quality framework into your specification is one way of doing that also, because you can work through the quality framework with your local Healthwatch, talk to them about it. How are they measuring impact, making sure the systems are in place. You can also gather stakeholder feedback. So there was, I think 8% of people said that they carried out evaluation conversations with stakeholders. So commissioners are using this model, but stakeholders will tell you, they'll give you testimony of the impact of your local Healthwatch, and you can use that to really show how it's valued by system actors. And I wanted to also just flag that social value-based monitoring and social value-based commissioning has lots of relevance to local Healthwatch, who are adding value through their sort of their work from a social value perspective. The other thing that I wanted to touch on is that regularly people come to Healthwatch England with their sort of commissioning conundrums, and I'm not suggesting that we're going to answer all of these today, but what I wanted to do just as we move into getting our local commissioners to share their experience with you is just to identify some of the questions that we get asked regularly. So people ask us, what are the different Healthwatch models? We already commission an advice and information service. Why do we need Healthwatch as well? Are we not already discharging our statutory duty? Are there examples of local authorities deciding not to carry out a full procurement and they've been able to just award the contract to an existing provider, for example? And how was that rationale used with their procurement team to make sure they were legally compliant? And what arguments are used by local authorities to protect the budget of a local Healthwatch? So often we find that commissioners can see the value of a local Healthwatch, but say if elected members don't, what tools, what arguments could be made to ensure that the budget doesn't get cut to the extent where a commission isn't effective? What are the pros and cons of grants versus contracts? If you're looking at joint commissioning, what things should be considered? Joint commissioning with another local authority, for example. How does the Healthwatch work with the integrated care systems? What are the implications of a short contract length for a local Healthwatch? Why can't you focus on outputs? Why can't you prescribe the number of enter and views, for example? And why can't you prescribe priority work like public patient participation groups or care homes, and what are the challenges for those? So they're the kind of questions that come to Healthwatch England, and they're also the questions that you all have the answers to within your community of commissioners. So we're hoping that in the breakout group some of those questions can be answered. But what I'm going to do now is hand over to our commissioners, who have very kindly and very generously given their time today to talk to us. We are just going to do one last poll because we're just interested to see the diversity of commissioning approaches that we have within the room. So there should be a poll being posted now to find out the model of commissioning that you have. And if you could complete that poll, I'm just going to hand over to Amanda. Amanda, if you would just like to say next slide when you would like me to move along.
Along today to give an update on what's been going on in Portsmouth. So I'm Amanda Mackenzie. I'm Public Health Principal for Portsmouth City Council, and I've had commissioning responsibility for Healthwatch since 2015. You go to the next slide, please, Jenny. Thank you. So I just thought it'd be good to give a little whistle-stop tour of where we are within our commissioning processes. So we commenced, as everybody else, 2013 with our initial provider. That contract ran its course, and we ended up having to go out to commission in 2016 to award a contract for 2017. And at that time, to help with developing our specification, we actually did a bit of a stakeholder engagement to look up the things that were important to all of the people within the health and social care area, and that's what we did at that time. Our provider, unfortunately, in 2019 actually then went into liquidation. And because obviously it's a statutory duty, this became a very political thing. And I'm going to go back to how this actually probably helped us a bit in the next slide. But we were able to, within, I think we had a month of not having a service, and we were able to direct award to a different provider until March this year. So we have to, because it was a direct award, we had to go through another recommissioning activity, but it was at that point, it gave us the opportunity to really look at our specification. And at this time, you know, Healthwatch England have been fantastic at supporting us going through that process, but also had produced lots of guidance, lots of support and lots of help around commissioning an effective Healthwatch. So that's what we used to really pull our specification together. And we awarded the contract to begin the 1st of April. So it's been running for a few months now to the advocacy people. Next slide, please, Jenny. So the things that we feel that have really supported, I guess, with our local Healthwatch contract, and also to support with the recommissioning and support with an effective Healthwatch was around the leadership and involvement of our elected members. So like I say, when the previous organisation went into to liquidation, it became all of a sudden very political. And actually at the time, and I'm sure there's a few Healthwatch England staff that will probably agree with me, because I did lean on them for support, especially Ollie, so thank you. But it, you know, it became a very political situation, and everybody wanted to be involved in it at that time, and actually that really helped support. It helped support with the funding, it helped support with priorities. It really put Healthwatch up there in the spotlight a little bit more. I mean, obviously we have a place on the health and wellbeing boards, and Healthwatch have been going for many years, so they've gathered that momentum. But I think really what actually got on the elected members' radar was that situation, and it's unfortunate it had to happen that way. But I also think then from then we've had regular invitations go out to the elected members to go to the public board meetings, and they have attended, and that's been fantastic. So that's really great. It's helped prioritise it. One of the things, I think has been really helpful is to look at the contract length. So the contract length for this particular contract we've offered is 3 years, but with the option to extend for another 4 on a 2+2 basis. So the entirety of the contract is 7 years. So I think that's been quite desirable and makes providers feel a lot more secure with the contract. And then the biggest thing I think that's really helped us is the use of the guidance to support the development of our service specification. And I'm not going to take all the credit for this. I'm going to say that actually Paul Hudson, I've put his details on the next slide, done a really good piece of work around pulling together the new service specification. And everything through the guidance, the checklist that Jenny referred to earlier, we made sure that we did include. So in terms of the quality framework, that's within there as well. We've got reference to the theory of change model, that's actually within there as well. And we felt it was really important to be very comprehensive, but not to the point of being able to be too prescriptive so that the delivery couldn't be flexible to needs. In particularly at this point in change, with obviously we were doing this recommissioning activity slap bang in the middle of COVID, and also with the development of the ICSs, we want to be able to have a level of flexibility as well. But actually what we've managed to do, and I think Jenny made a really, really good point about it being around looking at those, the impact, and that's what we want to measure. So what we didn't do, and yes, I can share this, I'm happy to share the service specification. I think it's already gone out to a few local authorities already, so happy to share that. But what we didn't do was to put our KPIs within the published service specification. We developed our performance indicators and what we wanted the impact to be, but what we then want to do is discuss them directly with Healthwatch once they've been awarded, so that we can look at actually what other things could we bring to that, because they're the expert in delivering this, not just us. So we wanted to work together with them to have that, and that's actually worked really, really well. Next slide, please. So a lot of this has already been said, so I'm not going to go over it again, but all of the guidance was there to support us, and we put links to all of this within the specification to support the new provider as well. And what was really helpful when we had those darker days with commissioning is having the Healthwatch England team to be able to go to have those questions, and I really do thank them for the support that they gave us over the years with this, which is great. So I've put my details on there, but thank you.
Thanks so much, Amanda. Amanda's going to be available for questions at the end. So we are just going to move on to Lorna Corbyn from Central Bedfordshire, who has also offered to share her, or agreed, not offered, to share her commissioning experience.
Thank you very much, Jenny. So I'm Lorna Corbyn. I'm a commissioning officer at Central Bedfordshire Council, and at the council we commission Healthwatch from our adult social care team, and so I know it's slightly different everywhere. Next slide, please. So we grant fund our local Healthwatch. They were set up in 2013 as a standalone organisation, so specifically as Healthwatch Central Bedfordshire. They're not linked to any other organisation. And they've been grant funded since April 2017. So that was on a 3-year grant to start off with, and then a further 2 years from April 2020, taking us on to end of March next year. And our current thinking as commissioners would be to continue on that grant basis. The reasoning behind us looking at a grant was they are a local organisation. They were set up as that standalone independent organisation. They've got the local knowledge and they are performing really well. We had no concerns whatsoever. And also that feedback from partners about that local knowledge was really important as well. The CCG were really in support of that too. And so for us, that was our key decision making. So we set up a set of grant criteria. There's a service description there. It is outcomes based, and we've got our set of KPIs which are monitored quarterly. and for us, it's kept that relationship going. Obviously, there are some challenges in there. Grant funding tends to be for a shorter term arrangement. As I've described, we've had a 3-year and then a 2-year. But having said that, and having spoken to our local Healthwatch, because we've got quite a good relationship with them, and because they've been in place since 2017, we've got a very open relationship. And their feedback was, while it can be seen as a negative, and obviously they do see other Healthwatchers who have a longer contract, for them, they feel that the benefits are outweighing the negatives. Because we're very open with them about our plans. We're already having discussions about what will happen in April next year with them. They haven't felt like they've had any instability or insecurity there to date. So long may that continue. Next slide, please. As I mentioned, we have got a great commissioner-provider relationship. We meet quarterly, as you'd expect for quarterly monitoring, but I do meet with the chief exec on at least a monthly basis for us to have a catch-up, to find out how things are going, to see what support we can give to each other, which is really helpful. And although they've got that focus, obviously, on that direct customer engagement, what's been really helpful alongside that is their support to us with our commissioning activities. So in their independent role, we have asked them if they would support with, for example, we were retendering our advocacy services. So they went out and spoke to people with experience of those services, provided us with a fantastic report that helped us with our tender process, and gave us some feedback that we probably wouldn't have got if we'd gone out directly. They've also been involved in tender evaluations where appropriate. So again, bringing the voice of the people and their experience of local issues. And that's been extremely helpful. Their interim view visits, obviously like everyone over the last year, have come to a little bit of a halt. Having said that, they work incredibly proactively, and over the last year they've trained in virtual interim view. Pluses and minuses to that. Obviously, if you're doing something virtually like that, it is you get shown what you're shown, and you can't have that experience of walking through. However, it's meant that the volunteers have had another string to their bow. Volunteers have been able to keep engaged with their work and what they're doing, and really kind of keep them going. They've continued to do a lot of other virtual working over the last year as well, around kind of virtual festival for older people. Their Just Ask events are virtual at the moment and hopefully going back out soon. And they have a very, very active young Healthwatch. So they actually have more volunteers in their young Healthwatch than they do in the adult side of things, which has been really interesting. And that young Healthwatch, again, have been going out and doing a lot more things proactively over the last year, and sort of coming to us and saying, this is what we're thinking of doing. For example, a pen pal scheme with our local care homes. So they've been buddied up and provided a great pen pal scheme, which is going so well, they're actually rolling it out to other voluntary care sector providers now as well, for people who are on their own. That relationship they've got with key stakeholders, I mentioned before the feedback from the CCG, and it was really clear during the vaccination programme that relationship is so important. Their feedback from them was that critical friend element and that independent sitting alongside is really key for them, and that was something they felt they wanted to see a little bit reflected more perhaps in future contracts, just not only to kind of be there to be that critical friend, but also to say to them, actually we understand those issues, and we can support you with that, and we can support you with engaging with people and getting more people on board with things. And again, that relationship with other voluntary care sector providers, and our adult social care contracts team who manage our care homes as well. Just again, providing that critical friend and just a different view on things that's coming from people. So for us, it was that relationship and that good, that proactive working and everything else that goes on there was really, really key to us, and something we really, really wanted to keep, which is why that grant process was really important to us, to be able to keep them locally. And if we could just pop on to the next slide. I've just included a quote in there from the Chief Exec of Healthwatch Central Bedfordshire, just to give her feedback on the process for them. And she really, when I spoke to her about this and asked for her feedback, her key thing was they are, as many others are, very, very small. They are they don't have a lot of core staff. It is more volunteers, and for them, being able to avoid that tender process where it is possible to do so and where it is within the law to do so, just means that they can carry on focusing on those statutory activities, and they don't need to worry about dropping something that actually is incredibly important to their board to do. So the feedback from them has been great as well. So that was everything from me, but I'm happy to answer any questions when it comes round.
That's fantastic. Thank you so much, Lorna. So we're going to move on to the Q&A, which I think Gavin's going to help us to facilitate. Gavin, I'm going to give you a bit of a warning when we get close to the end of the time when we need to go into the breakout groups. Right. Thanks very much, Jenny. I'm seeing various questions in the chat as a warm-up, but if you've got any questions, this is a chance to raise your hand and ask away. But while we're waiting for those, Chris, do you want to come in with some of the questions?
Yeah, of course, Gavin. Yeah, so reading from the bottom up, I can see Jacob's answered one of the questions, so I'll perhaps skip that one. So I think Avi was asking, is the engagement work part of your current spec or was a separate agreement made? I think that was for Lorna, I would guess from the timing.
Yeah, so I suppose what we generally see is the difference between commissioned work and the contract work. So we've seen certainly some specifications just cover both, but perhaps local authority colleagues might want to come in how they handle those sorts of arrangements. Don't know if Amanda or Lorna has experience of that kind of side of things, where there's a separate type of engagement activity that's been required by a provider in their area and wants to commission a Healthwatch separately. Lisa's got her hand up.
Yeah, hi Gavin, thank you. So in Buckinghamshire, we actually added some additional funding to the Healthwatch contract for specific engagement around commissioning projects. So we have 4 projects a year that we pay for, and we added an additional 57,000 to our contract to enable them to do that work, which seems to have worked really well for us in Bucks.
That's great, thanks, Lisa. And I think you know, there are other examples. For example, a Healthwatch that might provide specific support to, say, a parent body of for people with learning disabilities, for instance. So when they're doing a specific activity over and above their sort of statutory activity, that often gets reflected in a contract. Okay.
I can see Lorna's got a hand up. If you want to come in, Lorna.
Yeah, thank you. It was yeah, so it depends on the engagement activity for us. So if it's something relatively small, we'll have a conversation and see if it's something they can fit in within their resources. If it is something bigger, if it's a bigger piece of engagement, then we would discuss additional funding. It certainly would be a consideration. The things they've done over the last year for us have been smaller things, but there are some that are planned for the next year that we'll certainly be looking at extra pots of money for.
That's brilliant, thanks. And I suppose it just, for us as well, it reinforces the importance of decision making, because if they've got a really clear on decision making and their priorities, then anything over and above that becomes much clearer, really, about what their activities are.
Another question for Lorna from Jess at Southend-on-Sea. What similarities does the grant agreement stroke contract have with a specification you may run with as part of a tender? Are they largely similar, or are there differences? More flexibility / broader outcomes?
Yeah, it is a lot broader. You can't specify as heavily in a grant as you would in a contract. So it is a bit broader. It's certainly a lot more outcome focused than we would have gone with a contract, although obviously you can with a contract anyway. But it is, I mean, we drew it up together with Healthwatch and it is a lot more outcomes focused. I'm more than happy to share the service description that we have attached to the grant following this as well. But yeah, I think it probably gave us a little bit more flexibility to be a little bit more open and to allow for that, as was discussed before, allow for Healthwatch to continue to be their standalone focus rather than having things a bit more specified in there. Hopefully that answers the question.
Brilliant, thanks, Lorna. There's another one for you. How much work is completed for children's services?
It varies. So dependent on what the board have decided they're going to focus on, there's been more work over the last year because there's been quite a big SEND review happening. So they've been quite heavily involved in that, and particularly from a young Healthwatch perspective, they've been quite heavily involved in that. But it varies year on year dependent on the priorities of the board that they've set.
Brilliant. Thanks, Lorna. There's a couple of questions more for maybe Jacob and Sir Robert around lobbying the Secretary of State to establish ring-fence funding for Healthwatch. One of the questions was, why wasn't it ring-fenced in the first place? And the second was, are we doing any lobbying?
Shall I have a go, Jacob?
You start, Robert. Yep.
Well, some of you may know that I wrote a report some years ago on the scandal of Mid Staffordshire, in which I looked at the then systems for engaging patients and the public, and Healthwatch had just started, and I did comment that it was concerning that the funding for Healthwatch had not been ring-fenced, and frankly that is still my view. However, I don't think realistically there's any chance of that changing anytime soon. And there are all sorts of good local government reasons for that. But it does mean that it's quite a battle gaining transparency about the journey, as it were, of the money that comes from the Department of Health through the Department for Communities and Local Government to local Healthwatch and through via local authorities. And actually our team has been doing a magnificent job in uncovering that, which we now put in our State of Support report. So I think there's a need for local accountability as to how the money that comes from the Department of Health is spent, and I think that needs to be looked at. So far as funding is concerned for the work we're going to have to do at ICS level, we are in very constructive discussions with the Department of Health about that, who fully support and recognise the need for there to be additional resources to enable this to happen. Those discussions have not reached a conclusion yet, but all I can say is that we certainly have the full support of the department and indeed its Secretary of State, at least the last one. I haven't yet had the opportunity of finding out what the new one thinks, for that funding to be made available. How that is to be obtained is yet still a matter for discussion. However, I don't think it means that the local authorities can just sit back and relax and think they've got nothing more to do with that, because clearly they have an interest. All local authorities have an interest in what happens at or will happen at ICS level, and I think it's really important that local authorities remain engaged in that process. So I think what I see is will be a bit of collaborative funding actually involved in this, and indeed it might be argued that ICSs themselves have a role to play, providing some of the funding. So I think there are all sorts of potential alternatives that need to be looked at, and it may be that not the same thing will happen everywhere. But believe me, we have put in a strong business case in relation to how much what the resources should look like, and which has received a favourable reception, and it's a subject that's at the top of our agenda at the moment. So I'm afraid I can only ask you to watch this space. Jacob, of course, lives in that space and probably will tell you far more than I can.
I don't think there's much more to add, Robert. Just a reminder, I think, in terms of the ring fencing, obviously, as we know, the vast majority of funding going to local authorities isn't ring fenced. It's been a long held view that it should be up to local discretion how local councils spend their money to reach the kind of the best outcomes for your communities. So there is a lack of transparency around it. We often fall back on the original allocation for Healthwatch to give us an indication of the amount of funding that is coming from the department. So I mentioned earlier the LRCV grant, and I've mentioned in the chat as well, that's accounted for about a third of the original allocation that was given to local Healthwatch. So that's a good starting point to work out about the total pot you're receiving from government for the Healthwatch service. But as we talked about, money's not the only thing. There are a range of other things that you can do. We've talked about in the chat today. But and on the funding for the ICS, as Robert says, watch this space. We are working hard on that to make sure that we get the resources we need, so it doesn't stretch what is already there too thin, and we reduce our effectiveness.
Okay, thanks, Jacob. Can I just bring in Johal Ravinder, who's been waiting patiently to ask a question?
Thanks, Gavin. Yeah, hi. It's Ravinder Johal from Birmingham City Council. Just a couple of questions, really, and observations. I mean, I think you've kind of touched on this already, but I mean, as you've said, the pandemic has really highlighted the vital role that health watches play kind of locally. Now more than ever, really, in terms of engaging with our service users and making sure that their voices are heard. We're all acutely aware, really, of the health inequalities that have been faced by those from certain communities, whether that's the BAME community or the disabled community, so a number of communities, and a lot of that has been kind of exacerbated as a result of the pandemic. I'm interested to hear really how Healthwatch England are looking to pick up on those issues, really, and how you're going to be supporting, say, local health watches to make sure that they focus on this. So, I mean, you'll know that Birmingham obviously is a very diverse kind of city. And I know you've mentioned equality and diversity and inclusion, but what does that mean in practice? Because like I say, the pandemic has highlighted those health inequalities massively, really. So I just wanted to kind of hear from yourselves at a national level and then at a local level, what you're doing around health inequalities and addressing those inequalities, really.
Thanks very much, Ravinder. Robert, do you want to?
Well, it's increasingly apparent to us that this is the area in which to work, because after all, if we can get things right, the system can get things right for the seldom heard communities or those suffering most from health inequalities, then it's going to be better for the rest of us as well. I think a good example of what we are doing has actually been and I mentioned it again, the vaccine hesitancy report, which I noticed has received some favourable comment in the comments here, which was an in-depth piece of work, not going to ask thousands of people what they thought, but actually identifying communities, talking to, I think it was about 92 people in depth about why they were reluctant to have vaccines, and using that experience, because actually when you're talking about inequalities, these things are hidden if you just talk to people in general and at random. You need contact with communities, and I think that many Healthwatch now actually have considerable expertise in finding those minority communities within their area who have and identifying their needs, and also, but most importantly, finding how best to generate a conversation with people, and that can be very different according to which community or group one is looking at. And I think one of the dangers of the labels we often slip into, like BAME is one of them, is there's a tendency to treat them all so-called minority groups as the same and with the same needs, and of course that's just not the case. So you do need a degree access to knowledge and acquaintance with various groups, and I very much hope that we at Healthwatch England over the next year or so will help develop the expertise needed to reach out to different groups to find out what they need, and then translate that into messages about strategy and service provision. I know that may sound all slightly vague, but it's quite difficult speaking at a general level about something that has to be solved at a specific level. But I don't know if anyone else on the team wants to add to that.
Yes, if I could come in. Oh, go on, Jane. Yeah, go off you go.
I was just going to say that there's some really good practice within local Healthwatch of doing this work. They've been thinking about it a lot, and they've been reaching out. Obviously, key to it is relationships with the local voluntary sector, who already have trusted relationships with people that we would want to reach. But there are some local Healthwatch that have done some innovative things around recruitment of volunteers that can almost be like a peer engagement worker within a community so that there's a longer term relationship. And there are some pilot pieces of work going on around the network now, looking at engagement with groups to make sure that sort of inclusion and diversity is sort of first and foremost in the minds of their engagement pieces of work, which I think if anyone's interested, I'll put my email in the chat, and specifically around engagement, we can try and broker conversations with people who are doing this well already.
Yes, and we've just to build on that, we've been doing quite a lot of work with individual Healthwatch, particularly to share examples of where they're doing that kind of activity. So I think we're going to be building up a much stronger picture of what's happening around the country on that. Okay, and I've worked out how the names work in the chat, so apologies, Ravinda. But Narinder Sundar, do you want to come in? You've got your hand up.
Thanks, Gavin. It's just a question around health inequalities, because we talk about health inequalities in our strategies, in our reports. You know, it's a kind of a really broad and ambitious aim. And as Robert set out, in understanding your local communities, it's very complex. And we have these groupings, and BAME is just one that includes a whole range of different communities, a whole range of different cultural customs, and also managing and maintaining health and well-being. There's different ways within different communities. And I think it is right, as Jenny set out, to understand those local communities, but it's breaking down when we say our aim in this strategy or report is reducing those health inequalities. It's important to break down what that means. Health inequalities, as we know, is related to poverty, it's related to poor housing, overcrowding, and in recent work in Camden and Westminster that I've been involved in, it's multi-generational households. It's a whole range of factors that really influence someone's general health and well-being. And I would say from the work that we've done and what providers have told us and fed back, we're looking at different communities. And when we had the first lockdown and no household mixing, that had a massive impact on some communities that really rely on family members that might live locally to support each other in terms of support on a day-to-day basis, in terms of food, eating together, and all of those issues. And looking at multi-generational households where you may have grandparents and children, and a whole mix of looking at different needs, how people access information, the whole digital divide. And I've been very interested in kind of breaking down that health inequalities term, because it's huge. And I just wanted to say that because it's come up in so many conversations, so many meetings, and it's not so easy to say, what are you doing on this? You've got to look at your local communities. What are your local organisations saying? So thank you.
Narinder, I would love to chat with you about that offline as well. I know there's some really good work going on and sort of peer-led approaches to tackling health inequalities in Birmingham. So please do email me. I've put my email in the chat.
I will do. Thanks, Jenny.
Narinder, thank you for raising that point. I think it's all really, really important. And of course, the inequalities we talk about cross boundaries between different groups, but absolutely, as you say, how one solves those can be quite specific to individual groups. So there is that challenge. So I think there are two things I would say strategically about it. One is we need to ensure that whatever work we're looking at, even if it doesn't start off with a question about health inequality, we include in that work a question: what are we doing about the inequalities within that particular subject? And of course, not every Healthwatch in the country can deal with all these things on a generic basis. But one of the great things about Healthwatch is, because we've got a Healthwatch everywhere, that we have a means of reaching out to particular communities and finding out about them in relation to a wider theme. So I think that's something to hold on to. But the important starting point is to make this the priority question, so that we're thinking about it in whatever we do. And of course, part of that is we need to know the question needs to be asked, and so that's the first point. And so we actually need constant access to the people who actually know what is needed and where.
Thanks very much,
you.
Robert.
And I was just going to say, sorry, Gavin, in other strategic documents, because in your opening presentation, you talked about the long-term plan and the ICS infrastructure. It's complicated and there's lots of changes within CCG's kind of structures, but it is about knowing where you come in within your local strategic boards and forums and networks, and also making sure that there's proper representation. And that has come back to us in a number of meetings with various providers who are trying to make sense of all their ICS developments and the infrastructures and where they sit within that. Thank you.
Us all.
Great, thanks. I see Ravinder's just mentioned the public equality duty in the chat, and that's certainly something that we're doing as we speak with Healthwatch, putting on sessions to really explore what that means to the way that they operate. So thanks for raising that. I'm just, Chris, have you spotted anything else in the chat that has come to?
There's 4 more minutes left, so probably time just for one or
For
two more questions.
one last or two.
One
right.
and a half.
Yeah, okay. Chris, have you got anything?
I think we've covered the recent comments and observations. There was one query earlier. I'm just having a quick look. I think Mia's asking if we could do more national radio and TV work to promote Healthwatch generally, so that then the local health watches are more empowered by that. It's probably worth mentioning that we've had a media manager start with us this year, Anna, who's been really getting a lot of good coverage for us. Obviously, we don't have a huge budget at Healthwatch England, and TV, particularly TV adverts, are vastly expensive. I don't know if Jacob wanted to add anything on that subject.
Yeah, can do, Chris. So as you say, I mean, the budget's required for a widespread media sort of marketing campaign via TV and radio is sort of beyond what Healthwatch England can afford. But we do try as we can through the earned media, so through as Chris mentioned, our media manager, and through our campaigns that we do. So we ran a very successful campaign last year in partnership with the CQC, Because We All Care, which generated the highest ever volume of feedback we've had from the public. And we've got another campaign planned for this year where we can get the whole of Local Healthwatch on board, and that's planned for Q4. So those sorts of activities can really help us do promotion, but it is limited in what we've got the budget to support. But as Chris said, we try as we can with media coverage. Had lots of coverage recently about dentistry and access to GPs and issues that really are sort of very common. So tapping into some of those broader, very common issues, we hope we can also raise the profile generally of Healthwatch, as well as the work we're doing with specific communities around health inequalities.
And our coverage has been hugely increased, hasn't it? Sorry, Robert.
I was just going to say, I consider it a major part of my job to promote our media presence, and frankly, it's much better and free to get publicity through the work we do, and I think Jacob's given some examples of that, and I think you will find that there's been a lot more of that happening with Imelda, myself, Jacob, and others briefing and being in the media in the last year or so, and we are now, I think, increasingly an organisation to whom the media come for an answer to questions about which are raised, and our reports are now being published in a getting wider circulation than they used to. And the same applies actually with our parliamentary engagement. We are increasingly thought of by members of parliament as being a useful resource to inform them about what's going on in their own constituencies. and indeed for help on national issues as well. And I suspect with the health bill just starting its journey, we will find an increasing role within that. That's obviously quieter work, but probably almost as, if not more important, than being interviewed on the Today programme. But we do both.
And I think it's worth saying as well that Healthwatch England also supports Healthwatch with their local media activity. So we know that that's a major way that people get that kind of presence and attention. Okay, under strict instructions, I think, from Jenny to keep to time. So I think that will draw that to conclusions. Thanks, everyone. If there's any other questions, we'll pick up those outside of this session or in the wrap up, perhaps, if we've got a moment or two. Okay, so Jenny, are you going to tell us about the next breakout session?
Yes. Yeah, so we will pick up these questions. Hopefully we'll produce something at the end that sort of captures the things that haven't been covered today. There's a lot in there and some interesting themes coming out. I think we can explore some of those more now as we go into our breakout groups. Each breakout group will have a facilitator and you're welcome to put your cameras on. Just to reiterate, the breakout groups are not recorded, so feel free to speak freely. We are going to cover 3 themes in each of the breakout groups where you'll be given an opportunity to talk about the challenges that you face at the local level, what's your best piece of advice, and what do you need from Healthwatch England. So by the magic of technology, and I'm hoping Judge is the magician, he's going to press the button and you will all be sent into your breakout groups. We'll see you back here very soon. The magic of technology. Yes, there we go. Hello, everyone. Welcome back. I hope you all had a good, long discussion. We had a really, really good discussion in our group. What we're going to do now as everyone pops back in, just a reminder that we are now going to record this bit of the session. So your breakout groups weren't. So if you don't want to be recorded, you can turn off your cameras. So what we're going to do is just get 3 key points from each of the breakout groups. So I am going to pick on our lovely Healthwatch England colleagues to feed back. So let's start with Jacob.
Thanks, Jenny, for throwing me under the bus and coming to me first. So we had a really good chat. Started off just discussing how many new people, relatively new commissioners we had in the group, and quite a few of them were new. So, but actually, the advice from the more experienced people was using the quality framework. That was probably the strong thing that came through, and really drawing on that to help. And that was that best piece of advice there. I think in terms of the challenges, we talked a bit about grant making in quite in some detail, and actually who can make grants, how can you make a grant, how can you make it as robust as the process for having a contract in terms of the service spec in the grant. So that seemed to be something that people had an interest in exploring, but actually how do we make that work in a world where we have to have very sophisticated and grown up relationships with the voluntary and community sector in getting the return on investment for public funds. And in terms of that, what Healthwatch England can do to help, I think one of the strongest things there was, there were 2 things. One, when councils have to go out to tender for something, can Healthwatch England do more to promote those opportunities to other local Healthwatch in the marketplace? Because that sometimes they miss, local Healthwatch may miss opportunities to go for contracts. And the other one was around, this is my word, not the groups, but harass the Department of Health and Social Care for the funding letters to be published as soon as possible, because that's making lives very difficult. And I made a plea back out to our commissioners. The more of you get in touch with us to say that makes our job easier in petitioning the department to get their skates on with the funding letter. So that was the biggest ask from the group.
Thank you, Jacob. So we'll come next to Gavin.
Okay, thanks, Jenny. Yes, we had quite a lot of people who were very much in the first weeks of commissioning Healthwatch, or were filling in for colleagues who were similarly in that role. I think we started the conversation around the challenge of outcomes, familiar to people who've been supporting Healthwatch, around being able to claim outcomes, the period of time it takes to achieve outcomes, what are Healthwatch type outcomes, and the sort of different stages that have to take place before any sort of longer term impact may take place. So having some conversations around that would be really welcome. And then secondly, we had a discussion around, well, perhaps, how do you, to what extent can a commissioner set out the requirements really around particular areas, and the area that's particularly focused on was the sort of wider determinants of health and the importance of public health. So we had an interesting discussion around that as well. And then the advice was similar to Jacob's group. Use the quality framework, use your regional manager. So those sorts of things. And then a specific one, and this is quite an interesting one, was more opportunities to bring commissioners together like this, so they can specifically focus on things like, how's the quality framework actually working for you? What do Healthwatch outcomes actually look like, and how are they working out? And just sharing examples of service specs. So quite a pragmatic kind of session as well.
Fantastic. Let's go for Chris next.
Thank you, Jenny. So we had some absolutely fantastic contributions. For the first question around what would your one piece of advice be? I think Sabra in our group mentioned that she very much supports her local Healthwatch in terms of opening doors for them, making introductions, building relationships, helping them to build relationships, which hadn't really occurred to me as a thing a commissioner would do. And it was also mentioned that making your Healthwatch feel free to challenge you and ask you to explain your rationale for certain KPIs or certain approaches is also really important, which is good as well. And the second question, I think the key thing that emerged was the challenges around constant change, constant reorganisations in local authorities within workforce and within people's areas of responsibilities. A few people also mentioned how Healthwatch is a very small part of their remit, and in a lot of cases it won't be in someone's job description, or it might be alluded to. Thirdly, what can Healthwatch England do? I had lots and lots of suggestions for this, but I think one of the key themes was maybe putting together a quarterly meetup for Healthwatch commissioners, either nationally or by region, and just letting them talk to each other, share best practice, both among commissioners and among local Healthwatch, and perhaps helping commissioners to find their neighbouring commissioners too directly. I didn't appreciate this, but apparently it's often very difficult to just pick up the phone and get through to the right person, again, because it might not be referenced in someone's job description that they look after Healthwatch. You can end up, being passed from pillar to post. So yeah, plenty of things for us to go away and think about there.
Brilliant. Gosh, they're all quite different discussions as well, which I think is quite interesting. Right, so John.
Okay, well, thanks to my group for some really interesting conversation as well, with some overlaps and some different points. I think I'm just going to pick out the conversation we had around the differences in where the Healthwatch contract sits within the local authority in terms of department, or as Chris said, whose role it is to be commissioning it or monitoring it, and then ensuring that everyone else within the local authority who could benefit from the insight and work that Healthwatch is undertaking does actually manage to gain some sort of benefits, and also even understands what it is that Healthwatch is doing. And we talked particularly about making sure that local authority elected members understand what Healthwatch is bringing, particularly after elections if there are new people in role. I think the other points we talked about probably led on to a few asks from Healthwatch England. So I think firstly, there was an ask around sharing our understanding about how much local standing orders trump everything else in relation to whether a particular Healthwatch has to be commissioned through a full procurement process or whether it can be directly awarded. And probably tagged on to that just something about commissioning Healthwatch alongside other services. So there was an example of a Healthwatch that's commissioned alongside experts by experience contracts, and so they seem to go well together, and what's our understanding around that. Something about experience of Healthwatch working on primary care network level, and so there was an ask if we could share where that's going well or where that's going forward. I think that's about it, really. I'll leave it at that from my group. So thanks.
Thank you. So let's go with Alvin.
Thanks, Jenny. Thanks to the group as well for their contributions. So, sorry, I'm Alvin. I'm the regional manager covering London. So on the advice to new commissioners, there was a big kind of theme coming out on support from colleagues across other local authorities, so not being afraid to contact other local Healthwatch commissioners for their advice, to chat through things with them, to ask them questions, etc. And alongside that as well is reaching out to Healthwatch England regional managers or Healthwatch England in general and getting the support around commissioning an effective Healthwatch service, including getting support on with Healthwatch specifications. A challenge for one of the participants of the group was, because of the last year, just not being able to kind of have that physical contact with colleagues and asked questions about the specifications, asked questions about the service, and that was stressful and frustrating at times. And just the importance of getting support from line manager, kind of like the practical side of things, the well-being side of things when you're doing these, doing the specification and preparing for a tender, or just having conversations about what the Healthwatch service will be in the future. And there was something also about when somebody had tried to reach out to other commissioners, there was a bit of challenge for that person in that they didn't get a response from those people that they had contacted. So there's something about us at Healthwatch England, hopefully brokering some of that in the future. Well, we do that already, but maybe just in that particular case, as was mentioned. And just in terms of the ask to Healthwatch England, so somebody suggested, do we have a catalogue of specifications, Healthwatch specifications, so like good, bad, indifferent, so that there can be learning from it actually, rather than, because they were keen not to just take a specification, even though it's valued, not just to take it and copy it, but actually they want to work through it themselves and make it unique for their Healthwatch and local authority area. So yeah, I quite like that idea.
Yeah.
So I said I'd pass it on to you, Jenny.
A catalogue. Okay, yes, good. So let's go with Delena.
Thank you. The first challenge that we discussed at length was decreasing contract values, and also the extension of contracts without any additional uplift, and some of the challenges this poses for local Healthwatch. I know one individual spoke about the benefits of contracting with an organisation to host local Healthwatch as a way of partly dealing with that in terms of economies of scale in dealing with functions like HR and finance. But yeah, that was seen, and then another commissioner, I think Lorna, mentioned that even though they aren't able to hugely increase the value of the contract, they have provided in-kind support, like legal support. So there are additional things that potentially commissioners can be offering their local Healthwatch. The next issue that we looked at, and it's something that has been raised already, is that the majority of the population locally are often still not aware of the role of local Healthwatch and what it can do. And this also translated into an ask from Healthwatch England, in spite of, the challenges around costs. Local Healthwatch need a lot of help with raising their profile locally. So if there's anything Healthwatch England can do around that would be welcome. Another really, really strong challenge, and this also comes back to change, but also change of personnel amongst stakeholders within the health and care system, and how sometimes often recommendations can just get left. And there was an ask about the role of Healthwatch England in bringing more influence. And we know that we're already capacity building local Healthwatch around their ability to influence locally, follow up on recommendations, to be better at proving their impact. But there was a request for Healthwatch England to also do more with stakeholders in terms of making sure that they are aware that there is an expectation that there will be a response to local Healthwatch and changes as well. Thank you.
Thank you. And we've got Ollie.
Thanks, Jenny. Yes, we talked about the challenge for a new commissioner coming in to pick up the local Healthwatch contract sort of mid-cycle, where, for example, KPIs may have been set in a certain way for a while, and a Healthwatch provider organisation may have got quite used to reporting in a certain way. And of course, some of those KPIs may be more output than outcome focused. we talked about how important it is for a commissioner to communicate on an ongoing basis with their local Healthwatch provider, obviously allowing a local Healthwatch provider to make independent decisions about their work programme, but for a commissioner to truly understand what Healthwatch's plans were, where a Healthwatch was attempting to make a difference, the context in which it's operating, that then feeds the narrative. And then we then went on to talk about, and I think Alvin's just mentioned it, the sort of Delana may have mentioned the general awareness of Healthwatch, particularly within a local authority. We agreed it's a shared responsibility on us all to make sure that local decision makers are as aware as possible of what their local Healthwatch organisation contributed. And then in terms of from Healthwatch England, yeah, just to agree that more networking opportunities would be very much welcomed.
Great, thank you. So last but by no means least was the group that I was in, which was really interesting conversations. We talked about the role of commissioners, not just in commissioning local Healthwatch, but also in championing them within the local authority and with elected members, which is a tall order actually. And that sort of led to an ask of whether Healthwatch England, perhaps working with the LGA, could support engagement with elected members and bring them together to sort of share experience and learn more about local Healthwatch. We also talked about the challenge of sort of funding levels and whether grant versus full tender, and the challenges of sort of governance structures and the need to have good governance of an organisation, but also of a local Healthwatch and how that might be different, which led to also a couple of suggestions from Healthwatch England to perhaps bring the procurement people together. You know, we bring commissioners together, but would there be value in helping some of those conversations around standing orders and light touch regime if we got the procurement people to come together? So that's quite an interesting suggestion, and a really nice one actually is helping tool commissioners up by having some kind of risks assessment or kind of log of risks around what happens if you don't commission in a particular way, so that they've got that to sort of engage with their procurement people. So some really rich discussions, and I think from my perspective, this is the start of ongoing conversations. We can engage with commissioners differently now. You can engage across different areas. Healthwatch England's always brought commissioners together, usually at a regional level and fairly regularly, but through the power of Zoom, now that we're all sort of inducted into the digital world, we could potentially do this in different ways to pick up some of those things. So I think we're going to talk to Gavin now, who's just going to recap on the support that you can give, and maybe, I don't know, Gavin, if you want to make some reflections on what you've heard about what we could give differently in the future.
Yes, thanks, Jenny. Absolutely. I think we've got a strong message, I think, coming through that there's an appetite for more of these kinds of opportunities to bring commissioners together, as well as other opportunities to bring stakeholders. I don't know, Jacob, if you want to say anything about our stakeholder survey kind of thing and a reflection on the kind of input that came from that around the value of Healthwatch.
So I think in terms of the key messages came through from that, I think that the stakeholders are already recognising that local Healthwatch are doing a lot around reaching out to different communities. So we said in our strategy in particular that greater focus on health inequalities, and there's a sense that from stakeholders that we are already doing that. It's a really strong value proposition, I think, to local authorities and to ICS and NHS partners. So that was a really strong message coming through. I think there is still some questions though about the extent and the full range of work that we do as Healthwatch, that we need to make that clearer. So our stakeholders are often aware of a piece of work that we've done that's specifically relevant to them and their service, but they're not aware of the full range of impact that we're having, a full range of experience and expertise we can bring to the table. So there's more work for us to do on that side and promoting that amongst stakeholders. But broadly, very, very positive, and certainly elected members of local authorities are very positive towards Local Health Watch and the difference that we're making. They were one of the strongest groups that came out in the stakeholder perceptions research.
Great, thanks very much. So just to, I think we've had quite a lot of promotion of the role that regional managers do. I think what we particularly like at Healthwatch England is that we have an early conversation when you are thinking about any contract changes that are in the pipeline. So mainly to understand what your intentions are, and then to support you through that commissioning process itself. So again, that might be early conversations with other local authorities who are facing similar kind of situation as your own. We do like to check through the potential tender specification, just so that we can both make sure that we're bringing the sort of learning from the rest of the commissioning network to help you, but also to check that it's compliant with the trademark license and the regulations and the legal side of things. We've got, I think, plenty mention has been made of the guidance that's in the chat, and I think that's probably the main things. I think we've got a strong message that they're taking away, that we'll put on similar kind of events to bring commissioners together. But I just think we've had it's been a really great opportunity. It's very much similar to the ones when we had face-to-face meetings with commissioners back in 2019. I think what always comes strongly over to me is the enthusiasm and commitment to Healthwatch. I know you operate in very tight financial constraints, but there's always been a real commitment and appetite for really getting the best from your Healthwatch. So it's very much appreciated from Healthwatch England, and we look forward to working with you in the next few months. Okay, I think I've covered. I'm not seeing the slides, so I can't see if I've missed anything. But I think I've covered all the main bits and pieces. So I think it just remains me to say thanks very much, everyone, for coming along. I don't know if we haven't got Robert still on the call, but Jenny, do you want us to wrap up?
Yeah, I was just going to say thank you so much for everyone coming along. I think we were overwhelmed with the number of bookings that that came through and the number of you that have been able to join. And we have an evaluation which will, I think, either be posted in the chat, but also will be sent on to you. We'll be sending the slides and all of the documents that we can. I think the key takeaways for me are that we need to help broker conversations around health inequalities and co-production. That we need to think about the events and the stakeholders that we sort of are able to bring together around different more focused topics. We are working anyway to strengthen the guidance and the toolkit that Gavin referenced earlier, and I will make sure that we take away some of those questions around the standing orders and the light touch regime to see if we can strengthen sort of what advice could be given around that. We will bring all of the questions out of the chat and either follow up individually or try to sort of pick up on common themes, and we'll include that with the papers. And don't forget that your regional managers can help broker connections, either sharing documents or sharing relationships. So they're your key, really. If you've ever got any concerns about anything, you're facing cuts, you're trying to pull together an argument to support your local health watch, then speak to your regional managers in the first instance. So thank you very much, everyone, for coming along, and I am sure that we will see you all again soon.
Great. Thanks very much.
Thanks.
Thank you.
Bye.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Still a couple of people on.
Yeah, shall we just jump on another?
Yeah. They might have. Yeah, should we just jump on? We'll catch up.
Yeah, I'll just jump in. Yeah, let's just pick up.